Hello there. Welcome to a new year and another session of Digital Slide Review and Sign Out. I'm Dr. Lewis Hassel, coming to you from the campus of the University of Oklahoma. Our program is part of the Path Presenter and Digital Anatomic Pathology Academy collaboration. And today our case comes from the realm of GI pathology. The patient is a young person, fairly young, mid-30s, a woman who has a history of HIV infection. Of late, she's had some significant diarrhea and weight loss, and there's been some concern about her compliance with her antiretroviral therapy regimen. And in fact, it appears as though her CD4 counts have dropped below what would be optimal for a person in her range. So given this situation, certainly the likelihood of an opportunistic infection in the GI tract as being responsible for this is highly likely. But I think we always have to remember that conventional infectious and inflammatory disorders, such as inflammatory bowel disease, do also occur in these patients, and we need to be aware of those possibilities. Among the opportunistic infections, we certainly think most commonly we'll count it as viral infections, particularly CMV, HHV-8 in the form of Kaposi sarcoma we've detailed on earlier videos. And then there's just the usual mix of fungal, bacterial, protozoal infestations that can go along with immunocompromised status. And of note, particularly in many of these HIV patients with low CD4 counts, their inflammatory response is very muted or almost absent. And so we may see things with just pure culture almost of microorganisms, whether that's Cryptococcus or some other entity. So our biopsies came from the duodenum, as you can see here, some nice villus architecture. A little bit of inflammation, but no obvious focal lesions. So we'll go down and just sort of start taking some scanning looks at what's here. The villus architecture is not blunted. The crypts appear relatively free of inflammation. And actually looks like she ought to be fairly able to absorb things, just looking here at low intermediate magnification. However, as we go a little higher here, you may begin to notice that there's just a little bit of busyness in some of these villus tips. A little bit of a funky look in some of these cells. And here's a few darker staining areas here. Go along and look at a few more areas along the way. You see here we've got some odd, slightly basophilic structures that could be nuclei or could be something else. And here we can see, again, a few of these little basophilic inclusions in the epithelium. More here. And here they're even clustered and almost sort of exploding out of the cell in some regard. So for those of you who've not observed this or seen this before, this is what Microsporidia look like in the small bowel. So what are Microsporidia? Well, they cause a diarrheal illness in our immunocompromised host, and particularly when the CD4 counts are below critical levels. But this is really an intracellular fungus. It can be found in various water sources, but is most closely linked to wild and domestic animals who appear to be the reservoir hosts. There are a variety of species, and they can infect a variety of areas in the human body. And they're fairly hardy because they can last as a spore morphology out in the environment for some time. They appear to directly infect the enterocyte via this, what's called the polar tubule, and then once inside, they begin to freely proliferate. So the CDC recently put out a nice diagram of the life cycle. And here you can see some of the various sites where they can infect kidneys, small bowel, large bowel, lungs, sinuses, and so forth, with different species, noting here that intestinalis can sometimes affect either any of these several sites. But we mentioned here they get the spores, they get a tubule, they inject their DNA into the cell, and then that begins to proliferate, take over a bit of the cell's machinery, forms new yeast forms, either each individually encapsulated or in a vacuole, parasitophorous vacuole. And then with membrane lysis, they're released out into the environment and the infectious proliferation continues. So with that sort of a setting, you may wonder, well, what do how do we make this diagnosis? Of course, microscopy is one way, but that's fairly non-specific. So other means are out there at possibilities. So one is a direct stool exam or direct exam of nasal aspirates, respiratory aspirates if you're dealing with other sites. And then these are stained with either an acid fast or a modified trichrome stain, as you can see here, or the acid fast on the tissue stain, which shows the presence of these organisms in abundance within the cytoplasm and then being expelled into the lumen outside of the cells. If we need to speciate them, then that usually requires PCR to be able to do that. Treatment for these is fairly conventional. There are some good treatments that are enabled to that, but obviously the most important treatment is raising that CD4 count, developing that native resistance, and coping with the immunosuppressive situation. So just as a sort of reminder, here's another case. In this case, a little bit more subtle, if you will. The last case, we seem to have quite a few of them, but I think in this particular example, they're fairly rare. And so it just sort of highlights the need to have an index of suspicion to get your clinical history right, and then look for them in the right places, and have a sufficient index of suspicion that you can identify them. Here's a few here. I know I looked hard on this and had a difficult time sometimes finding them. Here's a couple over here, and some of these cells. So you can see here in this particular sample, it's much more subtle. And you can come back and look at this. So we'll provide the link to these in the comments. Here are maybe some more here out in here. And sometimes these can kind of look like sort of upward migrating nuclei, but in fact they are the parasitic fungiform vacuoles that contain the infectious agent. And as you can see, there's virtually no direct acute inflammatory reaction in the epithelial compartment, or even much in the stromal compartment, maybe a little increase in plasma cells here. So our final sign-out diagnosis is intestinal microsporidiosis. This was confirmed to be intestinalis, and the patient was treated with the appropriate antibiotics and antiretrovirals so that we could take care of both the immune dysfunction as well as the microbiologic infestation. Well, thanks so much for joining me for this case today. We hope that if you like this, that you'll hit that like button. And as always, subscribing to our channel is a great way to both support us and to make sure that you get word when new videos are released, which we generally try to do a couple of times a week, and hope that in this new year that you'll find great engagement in your education and learning on this and other topics. So until next time, thanks for joining us on the Digital Anatomic Pathology Academy.